Hi, everybody. We want to welcome you to our series on peripheral nerve surgery. The overarching goal is to have a focused, high-yield journey into one of the most intricate and fascinating areas in neurosurgery, specifically peripheral nerve surgery. Whether you're a medical student or just beginning to explore the surgical landscape, a resident sharpening your skills, or junior faculty refining your specialty knowledge, the aim of these series is to designate some form of medical background in a case-based pearl anatomy, pathology, and surgical decision-making. Peripheral nerve surgery is unique. It sits at the intersection of neurosurgery, orthopedics, plastic surgery, and sometimes general surgery. Yet its training is underemphasized, and we want to demystify key concepts and try to introduce some cases and relevant clinical anatomy, diagnosis, manage common conditions, complications, and have an overarching discussion about functional zones of injury, high-yield clinical exams, timing and indications for nerve repair or treatments, new topics, new treatments, common pathologies, some intraoperative tricks of the trade, and each episode is going to be sharp, short, focused, and break into a lot of different topics that we are more than glad to cover. We want to bring in experts in the field and go over several cases. So this is just one of many. So thank you for joining us. And for our first discussion, I have my colleague here, Dr. Pisapia. He's an attending at Westchester Medical Center and assistant professor at New York Medical College. He's board certified in pediatrics and adult, and he has a thriving, growing practice. And for our first topic of discussion, as you will see, we're going to go over common peroneal neuropathy. So, Dr. Pisapia, what are the important elements for somebody to be aware of when evaluating a patient that has a concern for a foot drop? Specifically, how do we tell the audience how we can tease out common peroneal neuropathy in your clinic?
So history is always critical, especially in the field of peripheral nerve surgery. We could see in the diagram here that the common peroneal nerve is very superficial as it crosses over the fibular head, making it very prone to stretch or contusion type injuries. There are certain risk factors that I ask for. These include weight loss, excessive squatting, such as someone who gardens where there's hyperflexion of the knee, also habitual leg crossing. I'll ask about a history of diabetes, any injury on that leg, or any procedures on the leg as well. In trying to tease apart radiculopathy versus a peripheral nerve entrapment, I focus on the distribution of symptoms. So this middle diagram shows the sensory distribution of the common peroneal nerve extending from the knee down to the ankle along the lateral leg and the dorsum of the foot. I also looked at the motor exam. This diagram shows how the peroneal nerve divides into a superficial and a deep portion, and the peroneal nerve will control dorsiflexion and eversion. Inversion of the ankle is controlled by the tibial nerve. So if there's inversion weakness, in addition to dorsiflexion and eversion weakness, then I worry about a lumbar radiculopathy. Also, other history, including back pain with radiating leg pain or buttocks pain, would support a diagnosis of radiculopathy. And then in certain cases, there can be both. And we refer to this as double crush, where there's compression at the level of the spine as well as in the periphery.
Yeah, I completely agree with you. And, having your safety pin in the clinic to do pinprick examinations to localize specifically the areas of loss of sensation or diminished sensation is absolutely key. And reflexes in the clinic are also very helpful to differentiate different pathologies. And really having a thorough discussion, like you said, about the history is very helpful. I've caught a couple of patients, crossing their legs as a primary etiology of their foot drop or weakness in the peroneal nerve. And once they stop doing that, they typically recover. So I'm not sure if you saw any of those patients in your clinic.
Yeah, sometimes we try non-surgical treatments similar to the way that you may brace a patient with carpal tunnel, assuming they don't have significant weakness, progressive symptoms. But I agree. I'd also add that for peripheral entrapment, usually the symptoms are much more well-defined, the area of sensory loss or weakness. As you move more distally, more proximally, there may be overlap of the the dermatomes from a nerve root involvement.
Yeah, I love that pearl, more specific as you go distally, for the deep component in between the webs of the first and second toe. So it's very, very specific and localized, like you said, versus if it's more proximal, it can be very diffuse. A lot of patients come to our offices with EMG at hand as a diagnostic tool. Do you think those are helpful? What do you look for? What can you tell the audience on how to, obtain the pearls on how to look at those EMGs?
Yeah, absolutely. I think that electrodiagnostic tests can be very helpful as supporting data that could complement the history and exam. Um, for example, this is a nerve conduction study that shows slowing across the fibular head. So we see that measurements taken above and below the knee, we can see a drop off in speed, suggesting a level of entrapment, typically at the fibular head. Also for EMG, we can look at the distribution of muscles affected. So we see in this table, this is from a patient that I treated for common peroneal neuropathy. We see that muscles specifically innervated by the common peroneal nerve are affected, whereas muscles like the gastrocnemius innervated by the tibial nerve are not affected. So in helping, this is another way to help differentiate between radiculopathy and um, a peripheral neuropathy. So for example, if I see weakness in muscles served by the peroneal nerve and the tibial nerve, it makes me look more proximal, something like a sciatic nerve injury, lumbosacral plexus, or lumbar spine.
Another pearl that I typically look at is the short head of the biceps femoris, because this is more specific to distribution of peroneal nerve. Sometimes you'll get that on the boards, and even in your practice, if you have a good astute neurologist to localize the etiology of the foot drop, they can focus a lot on obtaining that short head of the biceps femoris muscle. And if that's involved, that typically is more specific to the peroneal nerve.
Yes,
Uh,
absolutely. That's a great pearl.
As far as any other testing, do you obtain regular imaging after the fact of this diagnosis, specifically looking at the peroneal nerve? If you are more focused, I need to go and do something surgical or evaluate that further. Do you rely on any other testing?
I do. For any entrapment beyond routine carpal tunnel, I usually would get some type of imaging, whether that's ultrasound or MRI. I think in the case of common peroneal neuropathy, it's especially important to assess for a mass lesion such as a ganglion cyst, because that could change management. These are some examples of representative images. The first one is a sonographic appearance of a normal common peroneal nerve in a longitudinal section. We can see the plus signs here are marking out the diameter of the nerve. We could see that in the setting of entrapment in the middle pane that there's enlargement here. You can almost think of this as there's a traffic jam occurring at this area of compression. So I find ultrasound is very quick and non-invasive. MRI is very useful as well and gives supplementary information about other structures in the area. This is an example of a peripheral nerve sheath tumor along the peroneal nerve at the fibular head. So I do routinely get one or both imaging studies before surgery to be more prepared.
I 100% agree with you. And I think the community as a whole is moving towards that as far as working the patient up with peroneal neuropathies. You don't want to be surprised. And ultrasound, you can have an excellent ultrasound machine in the clinic, and you can become very facile at looking at nerves and figuring out if there's any pathology there. And MRIs too can tell you the acute injuries from chronic injuries with muscle denervation changes or fatty infiltration into the muscle, and also growths like you're showing here. You're showing some images here. Can you go over what you're looking at here, if you don't mind?
Sure. So this was taken from a paper by Dr. Spinner and colleagues. On the left here, we have an intraoperative view of the different branches of the peroneal nerve at the level of the fibular head and slightly distal. So there's usually a small articular branch, which sometimes can be difficult to see intraoperatively. And then we see the deep and superficial divisions. This is a diagram of a ganglion cyst in this area. Unlike ganglion cysts elsewhere in the body, trying to resect the cyst completely can injure the nerve. But imaging can be helpful in trying to determine if the cyst is intraneural, meaning it's coming off of the articular branch, in which case the goal of surgery would be to section this branch, or if it's extraneural and arising from the joint itself, in which case a surgery, usually in conjunction with orthopedic surgery, to fuse the tibiofibular joint would be indicated. Sometimes you can have both, and some surgeons will perform both procedures at the same setting.
Yeah, that's a nice review, and I love the pictures. I typically just decompress the cyst, and if it recurs again, then would consider fusing that joint. That joint is not a single joint. There's a distal component to it too. So it could add more arthritis to the distal ankle joint. And, sometimes you can be just very successful with one attempt. And those ganglion cysts can migrate even further proximally. So it's helpful to get a nice MRI to figure out the extent of involvement. And they can really go into the tibial component too. So you have to be careful and in the evaluation of those patients. And I don't know about your practice, but I typically take out the articular branch so there's no further connection between the joint and the nerve itself.
Yes, these are rare cases, but yes, I agree with what you said.
So, I mean, you have that patient, and it's not an acute denervation. They obviously have a foot drop. They have not improved with therapies. What do you tell the patient? What's the expectations, and how do you perform the surgery to help patients with this condition?
Yeah, so for a patient that has had persistent symptoms or progressive symptoms, usually beyond 3 months, and have done lifestyle modifications, avoiding pressure on this area, let's say for habitual leg crosser, we would move towards surgery. And here's next slide shows a diagram of the incision. Typically, I'll feel along the distal outer lateral leg as I run my fingers up. The first bony prominence or bump that you feel is usually the fibular head, which is marked here. And I'll usually plan a small curvilinear incision slightly below that area. I'll usually position the patients in a semi-lateral position. I usually will do this under monitored anesthesia care with an IV with propofol. We'll have the patient, while they're awake, position themselves in a comfortable position on their side. I usually will place a pillow between the knees and pad the contralateral fibular head. Once they're sedated, I'll use a generous amount of local anesthetic and then make the incision. This was adapted from Susan McKinnon. Usually I'll try to find the nerve more proximally before it dives into the lateral compartment of the leg. The typical entrapment site here is shown, and this is referred to as the posterior intermuscular septum. In front of the peroneus muscle is an anterior intermuscular septum, and then Dr. McKinnon coined this phrase of the innominate or no-name muscular septum. I'll then decompress the nerve by sectioning these septums and then trying to pass an instrument such as a Penfield 4 or freer to make sure the nerve is freed both distally and proximally. I then typically will close the subcutaneous tissue, close the skin. I put a bulky dressing with gauze, a Curlex, and then an ACE wrap. And I allow patients to bear weight after the surgery. They'll usually go home the same day. I just ask them to modify their activity for 2 weeks to give time for the incision to heal.
That's nice. If you haven't had a chance, Dr. McKinnon has very nice videos. And, it's not just about the superficial component. You really have to decompress the back portion of those ligaments to decompress the nerve. And once you do it once, you'll immediately see what you should be tackling in surgery. As far as recovery, long term, what's the expectations? What would you tell your patients as far as how quickly do they recover? What do they have to do?
Sure. So in most entrapments, I find that patients usually have improvement in their sensory symptoms relatively quickly. So for patients with numbness or paresthesias, I find that improves in the first days to weeks after surgery. Sometimes with weakness, it can take a little bit longer. So usually if the incision's healed by 2 weeks, I then will have them return to physical therapy if that's indicated and they have weakness. Usually over the following weeks to months, we start to see improvement. I've had a handful of cases where in the recovery area, patients do have return of dorsiflexion, but I'd say that's less common. Usually it occurs over time.
Yeah, that's absolutely key. A lot of patients don't hear what you're typically saying as far as recovery, they expect to walk out of the hospital intact after the surgery. So try as much as possible to explain that and tell patients, hey, can you repeat what I told you as far as what your expectations are from the surgery? That's a good habit to do so they can truly understand what they're signing up for. And I agree with you with the pain and the cystesias, that those typically recover way quicker than the muscle recovery. And it's distance to target, so sometimes it takes 6 months at a minimum to see some form of recovery, but it's also patient dependent as far as age, risk factors, smokers, diabetes, and chronicity from the time of injury.
Absolutely.
One last question before I let you go. Have you had any experience with post-hip replacement sciatic nerve dysfunction and nerve decompression outcomes? I know there's some work from Dr. Wilson from Stanford. He looked into that topic specifically. Are you tackling these patients? Are you seeing those more often in your office?
I do. I've had several patients who have had hip replacements where there's likely a stretch type injury to the sciatic nerve, and the peroneal nerve division is usually more affected, or is the tibial is more likely to recover. Part of that is thought that there could be some tethering at the level of the peroneal nerve. I have offered and performed common peroneal nerve decompression at the fibular head in those patients, with the thought being that as the nerve is reinnervating, basically freeing the nerve at the fibular head can remove any roadblocks to reinnervation. And some of the literature has shown that the natural history is a comparison between natural history and surgery. Many patients after decompression will have higher rates of recovery of anti-gravity motor function after decompression. So that's something that I've adopted into my practice.
That's great insight. I think we need to, disseminate that information to our orthopedic colleagues to bring those patients earlier to our office so we can try to help them as much as possible. Not that everybody will benefit from immediate surgery, but having early touch base with the patient, figuring out who are the patients that are stalling and trying to help the ones that actually need it. So this is a critical population. They're elderly, their regeneration potential is slower. So it's upon us to go out and advocate for our patients and educate our orthopedic colleagues about these potential treatment options. Well,
I
thank you very much for this awesome discussion. I think we covered a lot, and hopefully we'll update you with more topics in the future, and we can get experts in our field to go over different etiologies and pathologies and help educate our community and be the shining beacon on that hill to spread the word on peripheral nerve surgery. Thank you so much, Dr. Pisapia.
All right, thank you.
Thank you.